Hello, my name is Ian McComb, and this is a lecture on psoriasiform reaction patterns, part of the Dermatopathology Made Simple series from the Australian Institute of Dermatology. Before we start, let's have a little look about examining a histo slide. You examine the slide itself, you look to see what type of biopsy has been taken, how many cuts have been done, and try and look at all of them if you can. First thing you do is look at the epidermis, especially the stratum corneum. And that's certainly the case if we're talking about psoriasiform reaction patterns. You're looking at something happening in the epidermis, so you start at the top down. And you're initially going to look to see if there's orthokeratosis or parakeratosis. Now, orthokeratosis is that sort of basket weave type pattern without nuclei in it. And it's the normal type of scale that's found on the skin surface. It's quite thick in areas such as the palms and soles of the feet. Normally you don't see a lot of it in disease, but what you do see in disease affecting the epidermis is parakeratosis. And this is where the nuclei of the keratinocytes are retained within the stratum corneum. And it generally indicates a hyperproliferative disorder, particularly things like, say, psoriasis, pityriasis rubra pilaris, but also some types of skin malignancy. For instance, Bowen's disease in situ, squamous cell carcinoma. PRP has a very characteristic pattern of alternating ortho and parakeratosis. So that alternation of ortho and parakeratosis, if you see that along with acanthosis, think of this condition. We'll come to it shortly. There's another little thing you may see called the sandwich sign, where you've got vertical layers of ortho and parakeratosis. And this is particularly seen in dermatophyte infections. And we'll try and show that a bit later too. All of these psoriasiform reactions, they're all part of the mnemonic PM's pet, the little cat called petal. PM's petal. And I'll go through what these various things stand for shortly. So you've looked at the stratum corneum. The next thing you do is look at the stratum granulosum. Is it there or not? We said there are some conditions in which it's absent, and certainly that's the case in psoriasis, and it's also absent in Ichthyosis vulgaris. There's a lack of the protein that's produced in the granules in the stratum granulosum in Ichthyosis vulgaris. The other thing you've got to look at that stratum corneum for, by the way, is to see if there's any sign of fungal hyphae or yeast forms. You may look at the slide and there's not an awful lot to see. But if you look carefully up at the stratum corneum, then you may see the fungal hyphae. Now, as I say, it can be subtle. You've got to look there. Sometimes you have to use a PAS stain so that these will stand out more prominently. Look at the epidermis then. Is it thickened or thinned? If it's thickened, there's usually hyperplasia or acanthosis. And this acanthosis is also seen in a variety of benign skin proliferations, such as seborrheic keratosis, but also in the inflammatory diseases such as psoriasis. Now, most of the other red scaly diseases will have a degree of acanthosis. But there's a particular form in psoriasis that goes by the name of psoriatic hyperplasia. And not only is there acanthosis, but you've really got prominent retiridges. And the dermopapilla are seen high up in the epidermis. You've got a thin suprapapillary plate. The plate of cells above the dermopapilla is quite thin. So it's time for us to look at some of these conditions. As I've said, all of them will be seen in the PM's petal. P for psoriasis, E for eczema, T for tinea, A for the annular erythemas, particularly erythema annularis centrifugum, L for lupus, lichen planus, Louis, syphilis, and occasionally even some light eruptions. So most light eruptions, the problem is going to be in the dermis. You're not going to have a lot of keratin formed. P at the beginning, pityriasis rosea, pityriasis versicolor, pityriasis rubra pilaris, pityriasis lichenoides, The M for mycosis fungoides. The S is for solar damage, because a lot of solar damage can be red and scaly. But S can also stand for scabies, because some scabetic lesions can be very scaly as well, particularly the crusted scabies. And S also stands for syndromes, because there's a variety of syndromes that are red and scaly. For instance, Darius disease, red scaly papules; Grover's syndrome, itchy red scaly papules; erythrokeratoderma variabilis, an unusual red plaque psoriasis-like condition. And I'm sure there are other syndromes that I haven't mentioned there. But, you know, if you don't think of that, you won't think of them. Okay, so let's have a little look now at some of these conditions. There's the clinical picture of psoriasis in a man's back. You can see the thick, scaly plaques. Many of them are joined up here. Often worse at sites of trauma, like down the center of the back there, where he's lying and is being irritated. You know, the classic areas for psoriasis are at the front of are at the elbows and the knees, also involvement of the scalp. But you can get it in flexural areas without the skin. So, you know, you got all that scale there. They're thickened. The epidermis is turning over 8 to 10 times faster than normal. So what are you going to see histologically? Well, you're going to see confluent parakeratosis, and that's what you're seeing in this here. See the little blue, the little nuclei here? In that layered parakeratosis, confluent parakeratosis. And by that we mean it's right along the top. You know, there's parakeratosis all the way along here, indicating the hyperproliferation. So it's not focal. Also look, sometimes you'll see little neutrophils in here as well. Neutrophils are the cells of psoriasis. And in pustular psoriasis, you get so many neutrophils coming into the epidermis, you get an actual pustule forming. Sometimes even in plaque psoriasis, especially irritated, you'll get neutrophils as a little collection up here in the stratum corneum, and these are called Monroe microabscesses. Now, in the spinous layer, which is down here, it's sort of commenting there that you may have neutrophils and groups there, and they're known as spongiform pustules of Koch-Gauge. I must admit I don't see these very often. It's usually the Monroe microabscesses that I'm looking for. Now in psoriasis, the epidermis will show this regular acanthosis. You know, there's the regular acanthosis. Look at that thickened epidermis there. But look at these prominent dermal papillae. There's probably a better one here, coming right up here, and some are being transversely cut here. They come right to the surface, and you've got a very thin suprapapillary plate. And if you look in these dermal papillae here, you'll find quite a few neutrophils sometimes. You'll sometimes see some invading the epidermis there as well. Now, in psoriasis, the granular layer is reduced, so sometimes it's absent. So you've got that thickened areas of parakeratosis, but no granular layer there. You know, no blue cells at the granular layer. You got a lot of dilated vessels in these dermal papillae as well. And those are the main things that we're seeing. So the hyperkeratosis, the confluent parakeratosis, acanthosis, big club-shaped reti ridges that often go quite deep as well, and dermal papillae that come up high into the epidermis itself. Here's another type of psoriasis. This is guttate psoriasis. You know, look at these small little plaques here, all scaly as well. This typically comes out after a streptococcal throat infection, and 7 to 10 days later, bang. And this may be the presenting feature of psoriasis in a lot of children. Now, in guttate psoriasis, they're saying that you may get some focal mounds of parakeratosis with some orthokeratosis in between. And there's less acanthosis of the epidermis than in ordinary psoriasis. You can still see some neutrophils, and they can go all the way up to the stratum corneum. But you know, it's slightly different, the histology in guttate psoriasis. Let's go on to another condition. Now, it looks a very characteristic picture, doesn't it? Look at all these follicular scaly papules. They're all centered around hair follicles. And here, they've all joined up. And there's little bits of sparing. But this is how the condition Pityriasis rubra-pilaris starts. It's an unusual condition. We really don't know the cause. There's sort of bimodal distribution of young children and adults over 50. And I tend to see it mainly in the elderly. But all of these papules can join up and they can become erythrodermic, just with some bits of islands of sparing. They get marked palmar plantar keratoderma. They get some changes in the face that give rise to ectropion. And the rash usually actually starts in the scalp, and it's often misdiagnosed as psoriasis because of the thick scale that's there. So what about the histology of this condition? Well, what you often get is alternating ortho and parakeratosis in both a vertical and a horizontal direction. Now, there is some parakeratosis up here and there's some orthokeratosis up here. But it can sometimes be seen in a vertical direction as well, alternating ortho and parakeratosis. And I suppose to that extent it can mimic the sandwich sign in some fungal infections. Now, note, there's still quite marked acanthosis there, okay? But in this case, you don't get you don't get loss of the granular layer that you get in psoriasis. It may be actually thickened or preserved anyway in Pityriasis rubra-pilaris, whereas it's generally lost in psoriasis. Characteristic feature you get, and we're not showing it here, is plugging. You know, sort of that follicular plugging clinically? Well, what you see is some parakeratosis at the lip of those hair follicles and some plugging in the hair follicle itself. It says here there can still be some thinnish suprapapillary plates, but generally they are thicker, this suprapapillary plate, than you'll see in psoriasis, and there isn't the same vascular dilatation, there isn't the same neutrophils in these dermal papillae either. They tend to be lymphocytes, occasionally even eosinophils and plasma cells rather than the neutrophils that you're going to see in psoriasis. So alternating paro and orthokeratosis, preservation of the granular layer, still clubbed epidermal, still clubbed retiridges, and not so thinned suprapapillary plates. So if we go a little bit further along that, mnemonic, psoriasis, eczema. Now, a type of eczema that's going to be confused, say, with psoriasis, is going to be red and scaly, without necessarily the weeping that you usually get in the ordinary eczema, is lichen simplex chronicus. And this is a chronic eczema that's been rubbed and scratched. The epidermis thickens up because of all that rubbing, and they often have quite a prominent stratum corneum as well. But that stratum corneum is mainly orthokeratosis. There isn't the hyperproliferation that you get in psoriasis, so it's mainly orthokeratosis that you see. But it can be thickened orthokeratosis. You've also got a degree of acanthosis. You've got quite prominent dermal papillae here. Prominent, I should say, retiridges and prominent dermal papillae. But there isn't the neutrophils in there that you would see, in fact, in psoriasis. And you can see, look how prominent that granular layer is. Now, you just wouldn't get that in psoriasis, okay? So, this is lichen simplex chronicus. The other thing you'll often see with this, although I'd have to blow this up, is collagen arranged vertically here, and thickened collagen in between these retiridges. We've said here the more chronic the process is, the more psoriasiform the changes are going to be in the epidermis. Occasionally you'll see, though I've said this is a form of dermatitis, you often don't see any actual spongiosis here. It's the same thing clinically. You don't see these things weeping much like in simplex chronicus. So spongiosis is fluid in between the keratinocytes that sometimes breaks through onto the surface with little erosions, and that's what causes the weeping. Well, you're not going to get that in lichen simplex chronicus. Okay, what other red scaly disease are we going to see here? This is, it's very interesting clinical rash. Look at these lines You know, they're stripes, almost like zebra stripes, except that they're pink and very slightly scaly. You sometimes have to get your finger on these to actually recognize that there's scale there. And this is a condition called small plaque parapsoriasis. There's a variant, large plaque parapsoriasis. Again, no great thickness of this. It's almost a patch rather than a plaque. And what do we mean by this condition? Is there any relationship to psoriasis? The short answer is no. It doesn't have any relationship to psoriasis at all. So, small plaque parapsoriasis can clinically look like psoriasis, but there are very few definitive histological features that we can see. Let's have a little look at this. That's an example of early large plaque parapsoriasis. There's a degree of acanthosis here. There's this infiltrate as well, but these aren't neutrophils. You look at these are lymphocytes. They're not quite in a lichenoid pattern. You know, they're not all hard up against the epidermis here. They tend to be a bit more perivascular, these lymphocytes, but they're extending beyond the vessels here. Overlying this is orthokeratosis. There's no parakeratosis in this. There's orthokeratosis. Occasionally, you may even get just a little bit of spongiosis, just a little bit of fluid in between the cells here. And that's all that you're going to see in large plaque parapsoriasis. The lymphocytes may look a little bit bigger, but they're not all that atypical. And there's no great invasion of them into the overlying epidermis. There may be a few in there, but you're not going to actually see little abscesses of them, little pottery microabscesses. That's what you get in the next stage. And that's where the lymphocytes dedifferentiate, become more atypical, and you get the condition of T-cell lymphoma or mycosis fungoides. And that's what you're getting there. You can see the scale is a bit different to the scale that you see in psoriasis. You're getting these plaques, in the patches initially that thicken up as more cells go into the epidermis. And the cells in the epidermis cause some irritation and cause some scale there. And sometimes you get quite figurate edges to these. But this is mycosis fungoides, the patch stage. What the atypical lymphocytes do is they show epidermotropism. They invade into the epidermis. And these lymphocytes will have varying sized nuclei and some atypia. And the more lymphocytes that invade the epidermis, the thicker these plaques will become. So patch MF changes into plaque MF. And it's at that stage it's much easier for the pathologist to make the diagnosis. So this is early mycosis fungoides. And what you'll see is quite a dense infiltrate of cells here. And if you look here, these cells are all lymphocytes. And the cells are invading now into the epidermis itself. You see them, let me just enlarge this one for you. You'll see the cells here invading into the epidermis itself. Now these are all lymphocytes, and if you look at them, if we went in closer, you'd see that the lymphocytes were varying now in size, the nuclei. And you can see here now, you know, whereas in large plaque parapsoriasis we had orthokeratosis, here in MF we're getting some parakeratosis on the surface. You've got the marked acanthosis, and you've got this denser infiltrate of lymphocytes, often quite hard up against the undersurface of the basement membrane here. You know, higher concentration here as they're trying to make their way into the overlying epidermis. The next one shows what happens when you get pottery and microabscesses. Here you've got these atypical lymphocytes. Look at the variation in the size of the nuclei here. And they're forming these little collections in the epidermis itself. And this is a classic feature of mycosis fungoides. We'll go on now, might come back to that picture in a minute. We'll go on now to another red scaly disorder, PET, psoriasis eczema tinea, or ringworm. often clearing in the center, scale extending right round to the edge here, the advancing edge of this. And this is tinea corporis. In tinea, the dermatophyte infection involves the stratum corneum. Why? Because these dermatophytes feed on keratin, and the stratum corneum is made up of keratin. So that's why they're there. It's also why they're in nails. It's also why they're in hair, because those are both solid keratin as well. So they're where the food is. So what do you see in a tinea infection? Well, sometimes you don't see awfully much at all. There may not be a great deal of epidermal hyperplasia. There may not be much in the way of infiltrate there at all. And you seem to have orthokeratosis here, and it's only if your eye picks up these little changes here in the top layers of the stratum corneum that you will in fact see that there are little fungal hyphae and bud forms in the stratum corneum up here. Now, occasionally, you may just see some neutrophils up there. So again, neutrophils up in the horn like that should have you thinking of tinea dermatophyte infections. Should also have you thinking a wee bit about psoriasis. Remember the Monroe microabscesses? But look, that's not really a psoriasiform hyperplasia, is it? And there's not a great degree of inflammation here. Maybe a little bit of perivascular stuff here, but that's about all. But you can see the fungal organisms along here as well. It's more obvious if you do a PAS stain. So make sure you always look. If something, you look at it and you think, I don't think there's much here, always make sure you're looking at the top layer of the stratum corneum and see if there's any sign of fungus here. Now, remember we said sometimes you can get alternating compact and basket weave layers of the stratum corneum here in this, and you can get a signage sign as well, alternating ortho and parakeratosis in some tinea infections. PETALA for annular erythemas. And this is probably the classic annular erythema, erythema annularis centrifugum. And sometimes these slowly enlarging partial circles join up and may give you a sort of serpiginous picture. Generally, the scale is a trailing scale. In other words, it's on the inside edge here in this condition. And it's a reaction pattern. It can be caused by a variety of things. It may be caused by a fungal infection elsewhere. It may be caused by a drug. It may be caused by internal malignancy, rarely. Sometimes food allergies. It's a difficult one to investigate. Lesions slowly evolve over a 2 to 3 week period, then may just disappear. So what are you going to see in an annular erythema? There's a bit of that trailing scale, so you should get a little bit of either ortho or parakeratosis associated with it. And what you may just get is a small layer of spongiose as well, and a little bit of parakeratosis, and not much else. But what you look for in this is the tight perivascular infiltrate, the cuffing that you see around these superficial dermal vessels. And it's lymphocytic when you look in. And you've got that little bit of parakeratosis there, some orthokeratosis, wee bit of acanthosis here, and that. And this is the trailing scale, you know, the parakeratosis that you're seeing up there. And this is the coat sleeve appearance of the lymphocytes. Now, there's a deeper variant of EAC as well, which doesn't have the degree of scale, but it does have involvement of the superficial and deep vascular plexus with this perivascular cuffing of vessels. And that's what you look for that variant. Now, this was just the whole thing highlighted. Let's just have a look at that in a bit more detail. Superficial and deep here, but mainly superficial cuffing. Little bit of parakeratosis up here, a little bit of spongiosis that you're seeing here, not much. You'd be torn here between a diagnosis of mild eczema or an annular erythema. You probably would with that degree of spongiosis. Let's look at the next condition. So psoriasis, eczema, annular erythemas, L for lupus, lichen planus, light eruption, L for syphilis, or Louis, the old name for syphilis. With the first three there, lupus, lichen planus, polymorphic light eruption, they don't give much for psoriasiform hyperplasia. However, syphilis may well give a psoriasiform hyperplasia on a biopsy. And, you know, secondary syphilis, like this, will give you a red, scaly eruption that looks somewhat like, say, gutted psoriasis. Remember that gutted psoriasis case? There's a bit of scale stuck on the center of all of these. That's a bit more necrotic there. That it can be a marker. You know, you might look at that and think, so that pityriasis lichenoides or something like that when you see the pleva variant, when you see that bit of necrosis. But with this guy, you'd look at the palm of his hand. You'd look in and see if you've got the red scaly lesions there. You'd look inside his mouth, see if he's got the features of secondary syphilis with the snail track ulcers. And you'd look round at his genitals and the perianal areas for the features of secondary syphilis there. So what do you see? Well, you're going to see some psoriasiform hyperplasia, especially the late lesions. There are not going to be a lot of changes in the stratum corneum. Most of it's going to be off the keratosis rather than parakeratosis. You'll get a superficial and deep perivascular infiltrate. But when you look at the cells here, instead of them being lymphocytes, a lot of them are going to be plasma cells. And these plasma cells may even invade into the epidermis. And you know, they can be applied quite tightly to the dermoepidermal junction here. There may even be some slight lichenoid, lichenoid changes here, vacuolar damage. But there's a lot of plasma cells here. Look at these big plasma cells, you know, lots of them. And it's this that makes you consider syphilis. Remember, biopsies from mucosal surfaces may often have plasma cells in them, but I mean, if there's biopsies from the chest wall and you see lots of plasma cells, boom, syphilis you certainly think of. Look at that psoriasiform hyperplasia acanthosis, and this fairly tight, well-bound infiltrate, but the plasma cells are the important thing. Okay, let's look at another condition. So, petal, psoriasis, eczema, annular erythema, and we've used Louis or syphilis. What about the initial P of PM's pet, the little cat called petal? Well, P for pityriasis rosea, pityriasis versicolor, pityriasis rubopolaris we've dealt with, and pityriasis lichenoides. What about pit rosea? Well, it gives you this lesion here. This is the herald patch with a bit of scale associated with it. Again, somewhat trailing. You know, it looks a little bit like EAC, but there's only a solitary lesion. Then you'll start to get these other lesions coming up a few days later. So this is the herald patch with the normal lesions of pityriasis rosea occurring along the lines of the ribs just a few days afterwards. So you got scale, and it's a bit red, and it looks psoriasiform. What are you going to see histologically? The degree of scale isn't great, right? So you're not going to get a thick area of hyperkeratosis on the surface. You get a rather undulating epidermis, and you can get some focal areas of parakeratosis. You'll also get a little bit of spongiosis. Now, you may have to look a little bit closer here to see that. There's a wee bit of lymphocytic exocytosis into that as well. But these lymphocytes won't look abnormal. The vessels, you get a bit of perivascular cuffing up here as well. Again, mainly lymphocytic. So it might look a little bit like erythema annularis centrifugum, but a little bit more spongiosis, a little bit more parakeratosis, but sometimes can be difficult, you know, to separate pityriasis rosea and erythema annularis centrifugum. Something that can help is if you get a bit of red cell extravasation. Let's see if we can look at this a little bit bigger. The red cells there, they may be still in the vessel rather than extravasated. There's your bit of spongiosis and the like up there, your bit of parakeratosis that we spoke about, a bit of acanthosis there. So you need a bit of a history to help you to make your diagnosis of Pityriasis rosea from this particular slide. So that was the other thing I was going to say here. That clinically, there are some atypical forms of pit rosea. You can get an inverse one. You can get some that are quite markedly scaled and inflamed. You can even get a bullous variant of Pityriasis rosea clinically. I must admit, I haven't really seen that much. You can get drug-induced variants as well. Now, in a drug-induced variant, you've probably got your infiltrate there may have some eosinophils in it, and that would make you think of a drug-induced variant. Let's go to the other P, Pityriasis versicolor. Now, this is usually it's a little bit redder than this, and the lesions aren't quite as big as this. There's a fine cigarette paper scale-like on the surface here that you've got to scratch with your fingernail to bring up. Let's see if we look at this here. But you might look at that and think, could that be mycosis fungoides? That's part of your PM's pet as well. No real, these don't form plaques. They may form little patches, and you've got that fine little atrophy. But that's, some early cases of mycosis fungoides, large plaque psoriasis can be like this. So you need to do some scrapings here to see if you can see this characteristic spaghetti and meatballs in the KOH preparation of Malassezia furfur, the fungus that's involved in this particular condition. And again, if you do a biopsy and look at it, this is the picture that you're going to see. Not really much in the way of acanthosis, perhaps very mild. Basket weave hyperkeratosis, and up here are the yeast spores in the stratum corneum. So that's the important thing to look for. Slight perivascular lymphocytic infiltrate, not much. It's another one of those conditions where you might look at the slide initially and say, what the heaven's name's going on here? I can't see much at all. And why you have to examine it systematically, starting at the stratum corneum and work your way down and see what you can in fact see. So generally, I find that a fairly easy clinical diagnosis, and it's rare for me to actually biopsy these. But remember, you'll get a red, slightly scaly area and a white skin. But if you've got tanned skin, your Pityriasis versicolor will present as pale hypopigmented areas, with the normal skin being the tanned skin. We see that a lot in this as part of Queensland where we practice. I said there, take your fingernail, roughen up the surface so you can see that fine Pityriasis or bran-like scale. And all these changes are going to be in the stratum corneum when you see that. So, what are we finishing up with? Here's a young fella with an area of hypopigmentation here. It doesn't seem to be much scale, but often you have to take your fingernail again to see that there is a little bit of fine scale associated with this. And this is the condition called Pityriasis alba. Now, it's typically seen in atopics. Atopics with an olivey sort of skin, and the eczema process, usually in the winter months, when the air's dry and you're losing a lot more water vapor from your skin to the surrounding air, and the skin's a bit dry, you're using soap, you're not moisturizing, then a wee patch like this will come up. And it's really just a low-grade dermatitis, low-grade eczema. So I've said it's low-grade eczema presenting particularly in tanned individuals in the face and the upper arms. The hypopigmentation is just that the process interferes with the normal production of melanin from melanocytes. It's not that there's any real reduction in melanocytes. There's normal melanocyte numbers along the basement membrane here. You might get minimal parakeratosis in the hypopigmented area, and a little bit of spongiosis. But gee, you have to look at it to see that. Those cells are a little bit separated there. You see the spaces in between. So you've got mild spongiosis there. Very little in the way of dermal inflammation. So, slight hyperkeratosis here. So the problem is another one of those biopsy specimens that may appear to have very little in it when you look at first. So you really need a bit of history to help you here. And you need to look closely for these fairly subtle spongiotic features. So that's an overview of some of the psoriasiform hyperplasias. Remember, they're usually part of the PM's PET. I haven't gone into the skin cancers, the solar damage. There's a whole variety of lesions there. I've mainly stuck with the inflammatory skin diseases. So, you know, if you look and the epidermis is made up of very typical keratinocytes, then you're thinking in terms of malignancy, particularly Bones disease and the like. And SCC, keratocarcinoma, etc. We'll come to these later, or we've probably done them earlier on in this series. But the purpose today was just to go over the various conditions that are part of the mnemonic, the PM's PET. So if you look, you see these epidermal changes, you know that it's going to be probably a red scaly disorder. You think of the mnemonic PM's PET, psoriasis, eczema, tinea, annular erythemas, lupus lacumplanus, light eruption, Louis, P for pit rosea, pit vesicular, pityriasis lichenoides, pit rubra pilaris. If you just think of that mnemonic, the M for mycosis fungoides, or the parapsoriasis ones, the S for solar damage, or some of the syndromes, such as Grover's, Darier's, and erythrokeratoderma variabilis, then at least these conditions come into your head. And when you're busy looking at the specimen, they just going over those conditions in your head should make you think of the histological features that you'd see in each of these, and you can rule them out when you're looking at the histopath specimen. I hope that's been of some value. We'll add some other conditions to this if we feel that it would be relevant. Thanks very much.